Delighted to come and talk to you about this guideline. We produced a guideline which was published in Anaesthesia in April of this year, after quite a long lag time due to COVID also. So this guideline was produced, essentially a little bit of background about it. This guideline is the first guideline related to this specific topic of management of vagus nerve stimulation therapy in the perioperative period. So despite the fact that vagus nerve stimulation therapy has been used for nearly 30 years, most commonly in the management of drug refractory epilepsy syndromes, there is very little guidance out there for non-neurologists in the management of patients who have vagus nerve stimulation therapy in situ. So there is the manufacturer, which is the global manufacturer is LivaNova. They have obviously got a physician's and technical manual. This is quite a voluminous document, and it would take you quite a bit of time to get through this document to identify kind of relevant points that are relevant to the perioperative period. So what we sought to do, recognizing this gap, we sought to create a succinct but comprehensive document for anaesthetists, intensivists, and anybody really working in the perioperative department, the entire multidisciplinary team, to be able to reference when they come across a patient under their care that has a VNS in situ. So VNS devices, particularly for the management of epilepsy, are increasing. It's a well-established treatment, effective treatment, but it's increasing in terms of the numbers of patients that are being implanted with them, and also the range of indications is also increasing. So it's very likely that anaesthetists, intensivists will encounter patients with the VNS in situ coming for non-neurosurgical procedures, so general surgeries, emergency surgeries, patients coming to the critical care unit. So what we did was we developed a working group of anaesthetists, neurologists, neurosurgeons, epilepsy specialist nurses, as well as neuroradiologists, to formulate a guideline that really encompasses everything in relation to the management in the perioperative period. We also wanted to give an overview of management in other settings, I suppose, where anaesthetists tend to be found. So that includes not only the operative department, but also labour ward for patients in the peripartum period, in the intensive care unit, and also for patients undergoing MRI, as we are often involved in the care of patients undergoing MRI and other scans. So in terms of the guideline itself, what we tried to cover was a brief background on VNS therapy and the current clinical applications and future potential applications. We did go through anaesthesia techniques for VNS implantation and revision surgeries. Of course, this won't necessarily be of particular relevance to anaesthetists working in centres where the devices aren't being implanted, but of course it's relevant to have an idea of how the devices are put in, and what complications or issues might arise in that setting. We go through a pre-assessment of a patient, any patient who requires VNS therapy, and this encompasses not only patients who are coming to have the device implanted, but also a patient who presents to you for another procedure with the VNS in situ. We outlined the specific non-therapeutic or adverse effects of VNS therapy, and the associated risks that presents in terms of how this might complicate a patient's course while in hospital. And then we culminate in giving focused recommendations for the management in these particular settings. So I'm going to try and kind of give a whistle-stop tour of all of that as quickly as I can, just kind of going through a brief summary of VNS therapy. So the first VNS was implanted back in 1988 for a patient who had intractable seizures associated with encephalitis, and this was successful in achieving complete remission in this patient. Another 3 patients were also implanted around this time, and they achieved significant reduction in seizure activity as a result of vagus nerve stimulation. And this led on to the formation of the vagus nerve stimulation study group and 2 RCTs, which clearly demonstrated a clinically significant reduction in seizure activity associated with high dose vagus nerve stimulation, as well as that long-term follow-up of patients in these 2 major RCTs did demonstrate that the vagus nerve stimulation had a cumulative effect over time and was able to achieve mean seizure frequency reductions of up to 50% after about 2 or 3 years of VNS therapy. And outcomes with more modern devices have sustained, and patients who have these devices implanted for the indication of epilepsy will most commonly have a significant reduction in seizure activity. A very small number will achieve complete seizure freedom. Some may at least achieve freedom from anti-epileptic drugs. And of course, the quality of life implications of that for patients who have intractable refractory seizures can't be underestimated. So since the first implantation and the subsequent RCTs between 1990 and 1994, the European Medicines Agency approved VNS therapy for the indication of treatment of medically refractory epilepsy in both adults and children who were unsuitable for resective surgeries or who had failed resective surgeries and persistent seizures. The FDA followed suit in 1997, initially approving it for adults and subsequently extending this out to children over 4 years of age. In 2001, research has continued into the potential applications of VNS, and in 2001, the European Medicines Agency then licensed VNS therapy for use in difficult to treat or chronic depression, and the FDA did the same in 2005. So as it stands today, according to the manufacturers, they've implanted more than 125,000 VNS devices since it's been initially licensed. The major indication continues or remains to be epilepsy, drug refractory epilepsy for those unsuitable for resective surgery, some patients with difficult to treat chronic depression, and there is ongoing research into clinical applications in chronic pain syndromes, Alzheimer's disease, cardiac failure, and obesity. So briefly, just with respect to the mode of action, so vagus nerve stimulation therapy falls under the umbrella of neuromodulatory therapies, which work by delivering a targeted dose of stimulation to a neural pathway. The VNS device itself delivers a regular and intermittent electrical stimulus directly to the cervical vagus nerve. Typically, after the device is implanted, there's a bedding down period, and then the device is activated 2 weeks later with incremental increase in the dosing. Stimulation parameters are individualized to every individual patient, and obviously this will depend on the dose required to achieve adequate seizure suppression, but also tolerability of side effects of stimulation, which becomes relevant when we get on to talking about problems that can be encountered. In terms of the mechanism of action, although it's been around for 30 years, the mode of action isn't fully established, but overall it is like many neuromodulatory therapies. It's proposed to be related to modulation of neurotransmitter release and modulation or adaptation of functional connectivity between different key brain regions along numerous pathways. The activation of vagal afferent fibers that project to the nucleus tractus solitarius seems to send signals to other brainstem nuclei, including the raphe nucleus and locus coeruleus, which are foci of monoamine producing neurons, which are increased. It also seems to act to some degree in the limbic system, but to what degree is unclear. And overall, again, it seems to modulate the functional connectivity between and within different brain regions, potentially suppressing the spread of electrical activity during a seizure. So just looking at the device itself and how it is implanted. So you can see the device on the left-hand side. So this is the LivaNova model specifically. So as I mentioned, LivaNova PLC are the global manufacturer for VNS systems for the treatment of epilepsy and depression. There are other manufacturers that are developing models for clinical applications like cardiac failure. These might vary in design, but they're not yet licensed. So I'm just going to concentrate here on the specific design of the LivaNova model that we will likely encounter in clinical practice. So essentially it consists of a pulse generator, which is implanted surgically in the anterior chest wall. This is connected to a single lead, which extends cranially into to connect to 3 coils, which are encircled or wrapped around the vagus nerve. One positive, one negative electrode, and then one anchoring coil, as you can see in the magnified image there. As you'll see in the image, this is implanted on the left-hand side of the patient, and this is the most common site for implantation because of the risk of activation of the right vagal efferent fibers, which may impact on sinoatrial node function, and the risk of bradyarrhythmias and even asystole associated with right vagal nerve stimulation is described. So most commonly will be implanted on the left-hand side, but it is not unheard of for patients to have one implanted on the right side, particularly if they've had multiple implants before and fibrotic tissue is developed and it's impossible to implant it on the left-hand side. You can see in the radiograph just to in the frontal chest x-ray, you can see the pulse generator there indicated by the arrowhead. It's not that clear on my screen here, but you might be able to see a little bit better the relatively faint line of a lead which connects to the coils which are overlying the area where the vagus nerve would be. So this is what it will look like. You can see a little bit more clearly on the lateral neck x-ray the lead itself and the coils. For all intents and purposes, just for comparison, the image on the left is still the vagus nerve stimulator. You can see how it compares to cardiac implantable devices. So in the image on the right, in the right-hand side of the chest is a pacemaker implanted. The pulse generator itself looks quite similar. The lead of the pacemaker is quite a bit more defined, and of course does extends caudally as opposed to the leads of the vagus nerve stimulator. But it is important to be mindful of patients who come in without a history, that this could be a vagus nerve stimulator as opposed to an implantable device. So to have this at the top of our heads, because it will have potential implications. I'm going to briefly just run through, in the interest of time, to get on to kind of the specific recommendations. I want to briefly run through the implantation and just the relevant factors. So as I said, two incisions are made, one in the anterior chest for the pulse generator, one in the neck for the mobilization of the vagus nerve and wrapping of the coils around the vagus nerve. It's most commonly carried out under GA because it can be a little bit uncomfortable, and these patients might not also tolerate lying still for over an hour for the procedure, although regional techniques, where necessary, have been described for implantation. The critical points of this is once the pulse generator has been connected to the lead, a lead impedance diagnostic test is performed to check the anchoring of the coils and the function of the pulse generator. This is a critical point for the anaesthetist to be very vigilant for the potential risk of bradyarrhythmia and asystole, which have been described in association with impedance testing because of the sudden surge in vagal tone. Another potential complication of implantation surgery is the risk that is of particular relevance is the risk of vocal cord paresis related to trauma to the recurrent laryngeal nerve. This is documented to occur in about 1% of cases, most commonly temporary, but has been described as a permanent complication, which will have implications for management of the patient later on. With respect to these patients will come back for procedures after the initial implantation. So they will have to have batteries of the device changed every few years. Some will have them done more frequently depending on the device settings and current output, because a higher current output will wear down the battery quicker. Battery replacement is usually a simple day case procedure where the pulse generator is extracted and batteries changed. It's usually performed under general anaesthetic, but if the patient is amenable, it could be performed under local anaesthetic if required. Revision surgery of the device is not surprisingly potentially more complicated, and this is usually done under general anaesthetic. So patients might have it revised if they have an old device in situ, or if they develop infection around the site of the device. Fibrosis after the device has been implanted for a long duration can potentially complicate lead extraction. Sometimes if extraction of the leads is complicated, sometimes the surgeons will leave the leads within the carotid sheath and then put replacement leads and coils either proximal or distal on the vagus nerve. I mention this just because it is critical for management of these patients there later when a patient comes for another procedure. It's crucial to know if any of an old device is in situ and where exactly it is in situ and how much of it is left in the patient. For either battery replacement or revision surgery, lead impedance testing is always performed to check the device. So again, risking bradycardia from vagal stimulation. We know that patients who are implanted with the VNS for the indication of epilepsy are likely to have a complex medical history with multiple comorbidities and likely will have an extensive medication history. So just in respect of our first recommendation, we feel it's crucial that patients are referred early for anaesthesia review, either as an outpatient or inpatient. Patients may be going for surgery in a non-neurosurgical centre, so it's crucial that contact is made with the relevant subspecialties, in particular neurology, in order to get as much information about the patient's condition and to get information with regard to the device specifically. This is a crucial step in safe management of a patient particularly outside of a neurosurgical centre. Of course, as with any patient with epilepsy, you're going to look at a detailed seizure history, and this will inform your management of the patient and management of the device, specifically looking at seizure subtypes, frequency of seizures, and triggers associated with seizures. Of course, you'll take a comprehensive list of patient medications and look for any potential side effects of medications. With specific respect to the device, you're going to want to gather very specific information. So as I mentioned, this will require consultation with the patient's neurology team. You want to know exactly where the device is. Is it on the left? Is it on the right? Is there more than one device in situ, or is there any part of an old device left in situ? As this will have implications for either scanning a patient while an inpatient, or use of diathermy and other electromagnetic electrocautery. You want to know when the device was last interrogated, and specifically you'll want to know the model that the patient has in situ and what settings they have. In particular, the relevance of the settings is whether or not the patient has any additional VNS features set, and these include auto-stim and magnet modes, which I'll explain. So every patient who has a VNS implanted will be given a personal device magnet. The function of this is that it can be used for two purposes. So the patient themselves can transiently swipe the magnet across the pulse generator in the chest, and this activates magnet mode, delivering an additional period of stimulation to hopefully terminate or shorten the duration of a seizure. And this is like on-demand vagus nerve stimulation. Alternatively, by fixing or affixing the magnet onto the pulse generator, this will deactivate the device temporarily as long as the magnet is sitting over the pulse generator. Once the magnet is removed again, VNS function will resume. Patients, when they come to the pre-assessment clinic or when a patient is reviewed, they are always advised by neurology to carry the device magnet on their person at all times. But this is a critical point to highlight to patients coming into hospital for any procedure, that they should have their device magnet, and any clinicians looking after them should be aware of where the device magnet is. However, in an emergency, if the patient doesn't have their device magnet and the device needs to be urgently deactivated, for example, in the setting of a critical bradyarrhythmia, any magnet with a strength over 50 Gauss can be used to deactivate the device by taping it onto the generator. A standard pacemaker magnet has a strength of 90 Gauss, so this can be used, and all theatre departments should have a pacemaker magnet easily accessible. Auto-stim mode or auto-stimulation is another optional feature of some of the newer LivaNova models. Effectively, what this is a feature of the device whereby the device picks up patient tachycardia that is a preset parameter of tachycardia, which it assumes indicates an oncoming seizure, and it will deliver continuous vagus nerve stimulation in response to the tachycardia. This feature, some patients will have the option on their device and won't have it activated, as it can be disabled independent from the regular intermittent vagus nerve stimulation. The presence or absence of this feature, or the activation of this feature, is of course significant for a patient who's coming for surgery, or a patient with critical illness who may have an underlying alteration of their physiology causing tachycardia. In that type of patient, you don't want to have continuous vagus nerve stimulation in response to the compensatory tachycardia. So other critical features apart from this to delineate from the pre-assessment are the presence of laryngopharyngeal dysfunction. So nearly a third of patients with refractory epilepsy have a history of or coexisting obstructive sleep apnea. And then the VNS device itself is associated with laryngopharyngeal dysfunction in up to 60% of patients with the device. This is caused by either left vocal cord adduction during the on or stimulation periods, or from traumatic vocal cord paresis. So obstructive sleep apnea may be either exacerbated in a patient, or it can arise de novo in a patient with a VNS in situ. Typically, patients will describe transient episodes of dysphonia, sometimes pain, sore throat, shortness of breath, and coughing during stimulation periods. And the significance of this is that there are described case reports of airway obstruction under anaesthetic with a supraglottic airway device. There's also a theoretical risk of aspiration from vocal cord adduction, so the anaesthetist needs to be aware of this. So in terms of the pre-assessment, we recommend that pre-assessment should seek for specific features of laryngopharyngeal dysfunction as described. Additionally, all patients who are having a VNS implanted will be screened for obstructive sleep apnea using validated scoring systems like Stop Bang and Epworth Sleepiness Scale. Some patients will go on to have sleep studies before VNS implantation, but it is always worth if you have a patient who has a VNS in situ and hasn't previously had a diagnosis of obstructive sleep apnea, it is worthwhile running through these scoring systems again to identify whether or not the patient has developed symptoms of obstructive sleep apnea since device implantation. So you've identified what the device is, you've identified any particular patient risks, and you've consulted with neurology about the patient's particular history of epilepsy or seizures. The question then remains, or the most pertinent question, I suppose, is what do you do with the device? So the big question is, do you deactivate the device or do you not deactivate the device? And the answer to that is that it actually depends, and it'll depend on a number of factors. So it'll really depend on patient-specific risks, so risk of patient, the patient's particular seizure risk in association with surgery or their admission to hospital. And it'll also be dependent on surgical risk or the particular risk of side effects of VNS during the perioperative period. So as we mentioned, bradyarrhythmia and asystole are a particular risk. This is reduced with left vagus nerve stimulator implantation. However, there are still a number of case reports that describe bradyarrhythmia, hypotension, and rarely asystole in association with left vagus nerve stimulation. As I mentioned, it's most common during the implantation or device testing after revision or battery replacement, but there are described cases of late onset cardiovascular effects, which can be significant. Another consideration is what the mode of anaesthesia that you're going to use for the patient. So the working party agreed that the risk could be heightened with the sympathetic blockade associated with neuraxial anaesthesia or analgesia. And in that circumstance, one would have a lower threshold to consider deactivation of the device to prevent complications. And further surgical procedures that are associated with profound vagal stimulation, one would have a lower threshold for considering deactivation of the device in this setting. But again, this would have to be considered on a case-by-case basis, considering specific patient-related and procedural risks. In general, the working party agreed that it was safer to formally deactivate the device prior to elective surgery and to then have it reactivated at the earliest opportunity. We agreed that if spinal anaesthesia is to be used, we would again recommend that the device is deactivated unless there are other particular reasons to keep it activated. With regard to epidural anaesthesia, the risk is less clear because the sympathetic blockade may be less pronounced, but we do advise caution in this setting. That all being said, in the emergency setting, formal deactivation may not always be possible, and it may not always be possible in a patient in another non-neurosurgical centre. So in that circumstance, what's critical is to have the patient's personal magnet or equally a high-strength magnet immediately available to deactivate the device should complications arise, if you are going to keep the device activated in the intraoperative setting or perioperative setting. The other risk of airway obstruction, as I mentioned, there are case reports of obstruction of the airway under general anaesthetic using a supraglottic airway with an active VNS in situ. Our recommendation, therefore, is that if the device is to remain activated under general anaesthesia, we would generally advise having specific caution with the use of supraglottic airway devices. Endotracheal intubation may therefore be safer. This can be, obviously this requires the discretion of the anaesthetist in terms of the procedure that they're having, any additional features of airway risk identified in a patient, or access to the airway during a procedure. So some of the other perioperative hazards which might influence a decision as to whether to deactivate the device or not are the the potential for electromagnetic interference. So our guidance on this was really gleaned mostly from the manufacturer's guidelines, which have quite clear guidance on this. So this was, significant to pay heed to those. So there is, they highlight that there is a theoretical risk of either patient harm or device malfunction or damage to a VNS, an implanted VNS, as with any other implantable device. Although there are case reports describing the use of monopolar diathermy, cardioversion and defibrillation without patient harm, some particular precautions should be observed. So of course the risk to the implanted device is dependent on the concentration of energy on any portion of the implanted system, which can result in nerve, tissue or vascular injury. So as I mentioned, if any portion of the device is left in situ, there is a risk of tissue injury, regardless of whether the device is on or off. So it is crucial to know whether a patient has any part of the device in situ. If there's any doubt, a chest X-ray can guide you in the right direction. With respect to the activation of the device, if the device is active, EMI from diathermy can also cause malfunction, either by suppressing generator output or reprogramming some of the parameters. And as I mentioned, the newer models that have auto-stim setting activated may equally respond inappropriately to what it senses as a tachycardia associated with electromagnetic interference, and this can trigger excess vagal stimulation, which can have deleterious cardiovascular effects for the patient. So our recommendations based on the manufacturer's guidelines and the physician's manual are to avoid the use of shortwave or microwave diathermy to reduce the risk of heating and tissue damage. Use bipolar rather than monopolar diathermy if possible. Similar to guidance for cardiac implantable devices, position the diathermy electrodes as far from the generator leads as possible, aiming to avoid placement that puts the device in the direct path of the current. Deactivate, you can independently deactivate the auto-stim mode prior to surgery in a planned elective surgery. And after surgery, at the earliest opportunity, the device should be formally interrogated whether or not it's been deactivated to make sure that the device is functioning as normal following completion of surgery with diathermy use. With regard to lithotripsy, they give some advice. Effectively, to deactivate the device, risk of malfunction of the device associated with it. With regard to defibrillation and cardioversion, the guidance is similar to other cardiac implantable devices. We should be formally deactivating it before elective cardioversion. In an emergency, if possible, secure the patient magnet to deactivate the device temporarily, but obviously do not delay any emergency procedure, cardioversion or defibrillation to deactivate the device. Position the pads in a front to back position in order to keep the current as far away from the generator as possible, and aim to use the lowest energy output as possible, and then again formally interrogate the device afterwards. To briefly mention specific groups, so in obstetrics, increasing risk of epilepsy identified in the EMBRACE report in pregnant women and associated with maternal death. VNS, there's very limited guidance with regard to or very limited literature on VNS use in pregnancy, although they are implanted in patients. Of course, you have to consider in terms of how you manage a device, we considered the particular physiology of a patient, a pregnant patient, in order to come up with our recommendations. Of course, you have to consider risk of VNS associated bradyarrhythmia and the risk to the fetus from hypoperfusion. Risk of this may be exacerbated by neuraxial anaesthesia. Peripartum tachycardia may also inappropriately trigger the auto-stim mode. And obviously, if a patient goes for an operative procedure in the peripartum period, EMI may trigger complications in the VNS device. This also has to be balanced by the risk of intrapartum seizure, which could be devastating to a patient. So our recommendations similarly follow that all patients should be referred to a high-risk obstetric clinic. We should have an individualized plan for device management during labour and delivery. So essentially balancing again in consultation with neurology and obstetrics and anaesthesia, balance the risk of seizures in a pregnant patient with the risk of the device causing complications. For vaginal delivery, if the device is to remain active, we recommend that continuous telemetry is used to monitor maternal heart rate and have immediately available the patient's device magnet to rapidly deactivate the device if necessary. We advise for elective cesarean section to deactivate the device, and in an emergency, you can use the patient's own magnet to deactivate the device. Of course, it should be formally interrogated. With respect to critical care, very briefly, slightly complicated in terms of these patients may be presenting with seizures as the underlying cause of critical illness, but equally if a patient is hemodynamically unstable, there is a risk that vagal stimulation could compound this effect. So early consultation with neurology services consider or certainly have a low threshold for deactivating the device with hemodynamic instability, deactivate auto stim mode, which could potentially cause excessive vagal stimulation in the setting of compensatory tachycardia associated with shock states. Be cautious with non-invasive ventilation due to the risk of apnea and hypopnea in conjunction with the VNS, which may be exacerbated if there is a reduced level of consciousness. Consider deactivation if any risk of airway concerns. We've also put in a vague recommendation with regard to tracheostomy. If a patient is likely to need a tracheostomy, it may be considered earlier due to the risk of vocal cord damage from repetitive adduction of the cords against the endotracheal tube. And of course, when you're putting in lines, avoid the ipsilateral side of the device. Specifically, very, very briefly, with regard to MRI, the post-generatory leads of the VNS are MOR conditional, so there are no known hazards within specified conditions of use. So each model of VNS and MRI will have an specific MOR exclusion zone that is specific to which is a body area that shouldn't be scanned under any conditions, and it is specific to each device model. It varies between areas between the vertebral levels C7 to T8 and L3. So you should consult specifically the manufacturer's guidelines for the model of VNS that the patient has in situ. The patient magnet and programming wand are more unsafe, however. Of course, there's a risk of lead heating. Patient may describe warmth or pain, vibration at the implant site. The risk of heating of the device exists even if, as I mentioned, if the pulse generator has been explanted already. So if there's less than 2 centimeters of the lead remaining in situ, the device is MOR safe, no exclusion zones apply. But if greater than 2 centimeters of the lead is in situ, or any part of the pulse generator is in situ, and the device becomes MOR conditional. Risk of triggering magnet mode by the MRI, causing excessive vagal stimulation during the scan. The device may malfunction or reset, and of course, image artifact may occur. So MRI should be avoided in the first 2 weeks after implantation. We advise, or the manufacturers advise, to deactivate the device in all cases to avoid inappropriate stimulation, and observe the device-specific exclusion zones if more than 2 centimeters of the lead is in situ, and interrogate the device afterwards. So just very briefly, key points: early and thorough patient assessment, MDT consultation with relevant subspecialties to devise an individualized plan balancing risk of seizures with risk of patient harm. We recommend generally that it's safer to deactivate the device for surgery to avoid related complications, but this should be on a case-by-case basis, and always have the pacemaker magnet at hand to deactivate the device in an emergency. So that is it. Apologies for the rapid run through at the end. There's quite a lot to get through.